Hello everyone, my name is Carlin Ulababian. I'm a fourth year medical student at UC San Diego applying into internal medicine, and today I'm going to be presenting a case of an interesting presentation of microscopic colitis. I have two main goals for this presentation. My primary objective is to review an approach to the diagnosis of chronic diarrhea, utilizing a diagnostic schema to subdivide the various causes into 5 discrete subtypes. In addition, I hope to elaborate upon the clinical manifestations, diagnosis, and treatment of microscopic colitis, a particular cause of chronic diarrhea that is often overlooked. Now let's delve into the case itself. We'll start with the one-liner. We have a 69-year-old male who's presenting with 1 month of watery diarrhea, weight loss, and oligoarthralgias. Additional history reveals the patient has been experiencing 5 to 10 watery, non-bloody bowel movements daily, 15 pounds of weight loss over the last 3 months, and pain and limited mobility of the right shoulder and left ankle. He denies severe abdominal cramping, fevers, bloody stools, or a preceding illness associated with his current presentation. Exam is notable for diffuse abdominal tenderness to deep palpation, and pain with active and passive movement of the right shoulder and left ankle without erythema or swelling. Initial laboratory evaluation was notable for a mostly unremarkable complete blood count and comprehensive metabolic panel, other than a slightly low potassium of 3.3. Further labs demonstrated a significantly elevated C-reactive protein, as well as stool studies which showed the presence of fecal leukocytes without identifiable pathogens or fat. In addition, a TTG antibody was negative. Further testing included x-rays of the affected joints, which were unremarkable, as well as an attempted synovial aspiration of the shoulder, which was dry. A colonoscopy was obtained and was grossly normal, as seen in Figure 1 in the top left of the center of the screen. By this point, our team had a strong suspicion of the diagnosis, a hunch that was ultimately confirmed on histologic analysis of colonic biopsies. The patient was diagnosed with microscopic colitis. Figure 2 is an image of the specimen obtained from our patient. It demonstrates both thickened subepithelial collagen bands as well as increased intraepithelial lymphocytes, ultimately yielding a histologic diagnosis of mixed, collagenous, and lymphocytic microscopic colitis. Prior to histologic diagnosis, we started our patient on prednisone due to our strong suspicion of an inflammatory cause of his chronic diarrhea. He demonstrated significant improvement within 2 days. Ultimately, after diagnosis was confirmed, he was switched to a different steroid, budesonide, and at 2-week follow-up he reported complete resolution of his symptoms. Now I'd like to discuss what I'd like to be the focus of this presentation, our proposed diagnostic schema for determining the cause of chronic diarrhea. Briefly, chronic diarrhea is defined as persistently loosened stool consistency and increased stool frequency over a period greater than 4 weeks. There's no standardized strategy in the evaluation of patients with this GI manifestation, which is quite unfortunate given the significant impact on the quality of life for patients affected. There are many causes of chronic diarrhea, and broadly, the most common causes can be subdivided into 5 categories: functional, malabsorptive, infectious, and inflammatory. Functional causes are the most common, and primarily include the diagnosis of irritable bowel syndrome, which is characterized by recurrent abdominal pain and altered bowel habits, with an otherwise negative workup. Notably, although this condition is prevalent, it is often misdiagnosed in the presence of organic disease, especially microscopic colitis, given the absence of findings on colonoscopy. There are a broad range of diseases that cause malabsorption in the small intestine, resulting in greasy, foul-smelling stools, weight loss and nutritional deficiencies, as well as the presence of fat in the stool. There are many causes of infectious diarrhea. However, most of these illnesses are acute. The differential for infectious causes of chronic diarrhea is much shorter and primarily includes C. difficile, Campylobacter, Giardia, Cryptosporidium, and Whipple's disease. Diagnosis of these conditions are primarily made via stool culture or PCR. Secondary causes are rare, but when they do occur, they are often due to a hormone-secreting tumor, resulting in persistent diarrhea despite fasting. Finally, let's touch upon inflammatory diarrhea, which is the highlight of our case. Typically, this presents with associated abdominal pain and diarrhea which may or may not be bloody. The presence of fecal leukocytes could be suggestive, however this test is neither sensitive nor specific and should not be relied upon for diagnosis. Notably, extraintestinal symptoms are common in these disorders and can be useful early in the workup to guide both the diagnosis and the treatment. The primary causes of inflammatory disorders are ulcerative colitis and Crohn's disease, which are associated with characteristic changes on colonoscopy. Often overlooked is the milder form of inflammatory diarrhea, microscopic colitis, which was the ultimate diagnosis for our patient. Let's briefly summarize the key features. It's a relatively rare disorder, mostly occurs in elderly females, and is associated with certain medications like NSAIDs and PPIs. The pathophysiology is not completely understood, however it is known to be inflammatory in origin, often involving lymphocytic infiltration of the colonic mucosa. The clinical manifestations include chronic, watery, non-bloody diarrhea, as well as possible fecal urgency or incontinence, or abdominal pain. Relevant to our case, extraintestinal manifestations are often present, most commonly presenting with arthritis that is non-erosive, oligoarticular, and peripheral. Other common manifestations include uveitis and other autoimmune disorders such as type 1 diabetes. The most relevant tests in the diagnosis are the colonoscopy and biopsy. The colonoscopy is typically unremarkable, demonstrating normal-appearing mucosa. The biopsy is necessary for definitive diagnosis and demonstrates thickened subepithelial collagen bands in the collagenous subtype and lymphocytic intraepithelial infiltration in the lymphocytic subtype. Our patient had both findings, which was labeled the mixed subtype. Finally, a brief comment on treatment. Mild cases can be treated with antidiarrheals alone, and more severe cases are treated with steroids, specifically oral budesonide. Now on to the discussion. In this case, we propose a diagnostic approach to chronic diarrhea by subdividing the condition into 5 broad subtypes. With this schema in mind, diagnostic evaluation can be guided by history and exam, and can be facilitated with special attention to extraintestinal manifestations. In this case, the presence of arthralgias raised concern for an inflammatory etiology of chronic diarrhea, prompting earlier empiric steroid therapy and expedited workup, which yielded a diagnosis of microscopic colitis. We highlighted the key features of this disease, including the epidemiology, pathophysiology, clinical manifestations, diagnosis, and treatment. In conclusion, I hope that this case can serve as an illustrative example of the utility of considering extraintestinal manifestations in the diagnosis of chronic diarrhea, and in addition, serve as a useful review of microscopic colitis, a disease that is often overlooked.